How y'all feeling? Y'all feeling good? Did y'all anybody go out last night? Y'all enjoy yourself? Y'all ready for Sundress and Six Seconds this afternoon? Do we have any first timers here? Okay, all right. Ooh, all right. I like it. I like it. I like it. Well, look, y'all gonna have a ball. Pace yourself. It's still early. It's 10:21. So gates open at 5. Get there at 5. Get yourself a seat. Show starts at 6. You'll have a great time. So we appreciate y'all coming out. So my name is Justin Valentine. So I partnered with Dr. Frank Jones. He actually brought this idea to me. I said, wonderful idea in terms of introducing the health component to Sundress and Seersuckers. We got thousands of beautiful black folks here from all over the country. And Dr. Jones, we talked about, we take for granted being in Atlanta, the access to health care and people that look like us. So we wanted to bring that to every individual here. We got a panel of some great medical professionals from all different organizations represented that look like us, right? So we wanted to make this a conversation. Please, please, please ask your questions, raise your hand, we'll bring the mic to you. But we want to make it a conversation. We want to ensure that everyone here has the questions answered about healthcare. We'll have the different physicians talk about their specialties, but we want to make it a good time. So we appreciate y'all coming out. Ask your questions, and I'll pass it over to Dr. Frank Jones.
Thank you, Brother Valentine. Well, welcome. Good morning. Good morning. How's everybody doing?
Good morning.
Everybody ready to get healthy today? It went to the boot camp, and y'all didn't see me in there, but I was in there working out. Y'all didn't see me. But no, we're here today for a very important reason. Oh, before I do that, we need a little bit more energy. Gotta get a little. Hey, Q's.
Yeah.
Hey, Q's.
Yeah.
Hey, Q's.
Yeah.
Hey, Q's.
Hell yeah.
Omega. Hey. Hey. Omega. Hey. Hey. All right, now we're ready. Now we're ready. Now we're ready. All right. All right. My name is Dr. Frank Jones. I am a general surgeon, trauma surgeon, critical care surgeon, and so happy to be here with you all today. And one of the reason we want to do is because our community is not healthy. We just aren't healthy. Some of it is genetics. Some of it is like the social determinants of health. But a lot of it is our habits. The brother's going to get mad at me with some things I say today, but that's all right. That's all right. But we have a panel of experts here. Everybody that's on our panel is board certified. They've written articles. They work at institutions. They've done presentations across the country. So we really have some experts here to answer your questions. And we know that during COVID, people kind of lost trust in doctors. And so we said, what better way than to have some divine non-doctors answer your question, people you know that you can trust. You can call your line sister, you can call your LB, your chapter bruh, and you can tell them, hey, go get that chest x-ray, go get that EKG. That's kind of what the thinking is behind this. So we have quite a few questions that we're going to go through. We're going to go through quickly. We're going to allow you all to answer questions as well. So our goal today is really to just educate you, get you thinking about your health. So let's get started. We're going to have them introduce themselves. First of all, this is my better half, my wife. We just celebrated our anniversary yesterday, 33 years. Yeah. Dr. Jada Bussey Jones. She's a primary care physician, so tell us briefly, Jada. Introduce yourself.
Well, I am an internal medicine physician, a primary care and inpatient medicine doctor on faculty at Emory University School of Medicine. That means I also do academic medicine and teach and research and all the things. And most importantly, perhaps, I'm married to Dr. Frank Jones.
and I didn't say I'm from Psi Chapter, Bloody Psi Chapter, Spring 83, and a proud member of Delta Mu Mu Chapter Incorporated. All right. So, Dr. Bussey, tell us, what is a primary care physician and why is it important that we see one?
Okay, so first of all, my husband is a surgeon, as he mentioned. We always have debates about whether surgery is better, internal medicine, primary care is better. Primary care is definitely better, more important. The evidence shows this. It is the only specialty, no offense to all my other colleagues up here, where if you have more of them in a community, that the community lives longer, right? So a primary care doctor is somebody who thinks about your entire person, not just your heart or your bones or your womb, your female parts. You know, again, you need those as well, but you need someone to be thinking about your entire person, managing your chronic conditions, but also thinking about before you get sick, how do you prevent things before they happen? So that's what primary care is about.
Okay. Another big question right now. Is it important to have, or what are the advantages of having a black doctor? How many of you all in the audience have a black doctor? All right, wow. Well, we're in Atlanta, so I guess it's a little bit biased.
Right.
Why is it important? Is it scientifically, is it important, or is it just a feel-good thing?
Yes. So first, we have to acknowledge that there are inequities in care where black and brown patients have worse outcomes overall. There is also evidence that says that when there is race concordance, that's a fancy name that means that when the doctor and the patients have the same race, speak the same language, that outcomes are better. Higher ratings of trust, more likely to get preventive services like vaccines and colonoscopies, and even things like infant mortality are improved in other conditions. So while it is important and it is advantageous to have racial and language concordance or similarity with, you know, like you can take that for granted, it's very important, but there are some things, even if you're a doctor, there are some well-meaning and other wonderful doctors of all races, that there are things that you can do. But yes, the answer is yes, that it is a good thing to have a black doctor.
And then tell us when someone's going to their primary care doctor for the first time or they haven't been in a while, what should they expect and what should they ask of their primary care doctor? Because you need to go into your primary care doctor knowing what you need. And so what should they expect at that primary care visit?
So the first thing I would say is that you may expect a history and a physical exam. You also will get some basic lab tests. And I think that this is a really good time to have screening and to check on the things that may be coming down the pike that you may not even be thinking about. But the one thing that I brought my list here, and I think that I want to have you advocate for yourself. So that may include having a list of things that you need to ask for. Again, whether your doctor is black or brown, you want to make sure that you follow your thoughts, make sure that your questions are answered, and that you are getting the respect and the care that you need. And so don't feel bad about advocating for yourself, even bringing a spouse or another loved one with you if you think that, if you want to do that. But it's very important that you go to the visit knowing your history, having your questions, having them listed out, and being prepared to engage in the care that you need.
Okay. All right. So we're going to take one question. We have a quick question back there, Brother Lyle. If you have a chance at the end of this session to ask a lot of questions.
So you mentioned that it was good to advocate for yourself, and you also mentioned the disparities when, so if someone has a physician who's not black, say they have a white doctor, how can they talk about the discrepancies and the problems without offending the doctor, but hopefully getting the best level of care that they would if they had a black doctor?
Great question.
Yeah, I think that, again, I think whether you have a black or white doctor, we all sometimes bring our assumptions into the setting. Sometimes people are rushed. And so if you're not getting the answers that you want, just mention, hey, I'm not sure. You know, this happened to Serena Williams, for example. She talked about during pregnancy, she was having chest pain. The doctors weren't listening to her. They said, oh, maybe it's just medications. She had a pulmonary embolism, and they didn't hear her. And so that's where sometimes, like I said, you ask the question the second time. Sometimes you have to find a different doctor. If that doctor is not listening to you, you have the power to change that relationship and seek the care that you need.
And just because you have a black or brown doctor, they may not be the right doctor for you either. So you still have to find somebody. One more. We're going to come back to you, brother. We're going to keep going.
Good afternoon, everyone.
Hey.
I want to talk about Atlanta's physicians. I'm 7 weeks out of ACDF surgery. Ortho, Sport, and Spine gave me my life back, okay? And I have black doctors in my family.
Excellent.
Okay? So congratulations to all of you, and thank you for inviting us here.
Thank you for coming. Thank you for coming. We're going to come to you again, bro. Let's keep going. Next, we're going to have Dr. Bourne. And tell us who you are, what your specialty is.
Hey, good morning, everybody. Evan Bourne. First of all, I'm trying to not feel some sort of way on the panel here with all these esteemed professional black women, but Evan Bourne, I pledged at Emory University in spring '91. And I'm a primary care physician also, and I practice in the Cumberland Mall area, doing mostly concierge medicine. But my thing at this point is really in the diabetic and obesity space, and I never thought I would be there 15 years ago. But at this point now, I find myself doing a lot of speaking nationally and internationally for all these medicines like Ozempic and Mounjaro and all the things that we're seeing on social media. And I do a lot in the obesity space as well, and development of new products such like as new insulins and such. So,
okay. First question: what is pre-diabetes? What's the difference between pre-diabetes and diabetes, and what should the patient take away from that if they're pre-diabetic? Should they be worried?
yeah. So I think the thing to really consider here is that we define pre-diabetes as a number. Right? If we're looking at just a fasting blood sugar, we're looking at a number that's in a certain range. If we're looking at diabetes by a A1C, we're looking at a range, a number that starts at like 6.4, 6.5. But the thing to keep in mind is that if my sugar's 99 and then 100 defines pre-diabetes, it's a continuum, guys. You're not you're not out of the woods if you're 1 point away, right? I'm a numbers guy. There is about a third of our country that is pre-diabetic right now, okay? And that's an A1C higher than like 5.7 in that range to 6.4, all right? There's about 13% of us that are diabetic in this country, which is pitiful. And there's a lot of reasons to that, as Jada, kind of mentioned some of those things. But yeah, that's the key. And pre-diabetes, if we do nothing, has about a 5% chance per year of turning into overt diabetes.
And so what are some of the common signs and symptoms of diabetes? Because there are a lot of us walking around, we have no idea. And then how do you actually diagnose it?
So as I said, about 3 to 4% of people walk around for years have no idea that they have diabetes, all right? So in answer to Frank's question, the signs and symptoms are all over the place. The common ones that we all learned about in school are excessive thirst, weight loss, urinating a lot, feeling blurry vision, right? So the signs and symptoms can be a little bit of everything, and it's rare that I see somebody come in with the classic signs and symptoms. So if I had to give a take-home message about symptoms of diabetes, I challenge all of us and tell a friend, get checked, get screened for diabetes, know what your A1C is, know what your fasting blood sugar is, and demand those tests, even if it's not on the panel that your doctor says is normal for a physical exam.
There's a lot of new drugs out there, and Dr. Bourne goes around the country speaking about some of these medications. Kind of put in a capsule for us and tell us, what are these new medications? Are they healthy? Are they dangerous? Should we be on them? Tell us a little bit about that.
So I think, you're obviously referring to the new treatments in the diabetic medications, right? Mm-hmm. The whole class of medications, we call them incretin therapy or GLPs. You may hear that word. But basically, these new medications, which were designed initially in the diabetic space, when we started using them, and they've been out for 15 plus years, when we started using them, we just saw that, one, they had a lot of benefit outside of diabetes, right? So they helped these pre-diabetic patients not develop diabetes. And the biggest thing we saw is that a lot of these patients just started losing a lot of weight on these medications. And the weight loss, we know, can really change the trajectory of somebody developing diabetes or the complications of diabetes, including heart disease, kidney failure, stroke, neuropathy. It goes on and on and on. In answer to your question about safety, a lot of these meds go through all these safety profiles, safety checks. I do some of the studies with things like this. And, I think what I would say is, for the right person, if you ask the right questions, and the doctor makes sure that this is the right medication for you. They are generally very well tolerated and safe, but make sure that you are having that conversation with your physician.
And hold on one second. I wanted to say this as part, again, of why we're here. I bet that every one of you in the audience has a line brother, chapter brother, church member, somebody that's young that just died suddenly. That happened to me. 2 of my line brothers died within 2 months of each other. Young, healthy people. I bet 90% of the brothers in here know one of my line brothers, Grease. Grease is known all over, just died, went played golf one day, died the next day. That's what we're trying to prevent, because there are some simple things that we can do to help us get healthy and stay healthy. So I wanted to bring that perspective to it. Next, we're going to switch gears to Dr. Julianne Adams-Burke. She's an OBGYN, so tell us briefly who you are.
All right. Hello, everyone, and hello especially to the ladies of Alpha Kappa Alpha Sorority Incorporated. I became a member spring 1993 at Clark Atlanta University, Sweet Alpha Pi, and currently serve here. I'm not from here, but I've been here since the age of 18, and I now serve in a chapter out in Stone Mountain, Lithonia. So I am a board-certified OBGYN, but like I told my soror earlier, I gave them babies up 6 years ago. Babies are so disrespectful with your time. So I am now focused only on women's health and gynecology.
Okay. And do you have a special office that you're getting ready to assume within the next week or so?
Oh, well, yes, Dr. Jones. So, your husband, child, your husband. Thank you. So, next Saturday, actually, I will be installed as the next president of the Georgia State Medical Association. And that is the black organization that serves not only African American physicians, but it helps us to serve our communities better.
We got some heavy hitters up here, y'all. I mean, some heavy hitters. I know this is going to hit home with quite a few people. What exactly is menopause?
What?
Oh,
Where them
Lord.
fans at? Where them fans at? Woo! So menopause is the cessation of your menses at least after the age of 40. Okay, so if you go a full 12 months without your menstrual cycle, that is most likely menopause. And notice I'm saying most likely because perimenopause, which is the journey towards menopause, can be the great imitator for a lot of other medical conditions. But menopause, that is the general definition. Once you stop having your menses for a total of 12 months, that next day, 365 or 6 days later, you could go put that label across your head.
And how long, I already know the answer to this, but how long does menopause last?
Oh, Lord.
And what can you do to mitigate it?
So what he's alluding to are the symptoms related to menopause, because menopause really, I just said, it's a kind of a day. It's a date, and you don't get there until you get there, right? So everything before that is peri, right? Premenopause is really the women who are still able to reproduce or in their reproductive life. They're ovulating every month, that kind of thing. And then postmenopause is that day after. But the symptoms of menopause can occur during the peri phase, while you're in menopause, and even after. In America, there's several, of course, studies, but we say that the average woman in America goes through for 4 years. But you know you black and you different, right? And so black women, unfortunately, can experience those symptoms for 10 years. On average, because I know y'all, some like, well, I've been going through it for 15, or my mama's been going in for 32, and that too can be true.
Okay. Switch gears just a little bit and just tell us a little bit about maternal fetal health. And why do we have so many problems with maternal fetal health? Our black women are dying in the perinatal period. Why, and what can we do about it?
Great question. So, well, the first thing is one of the reasons we are here today, and that is, trying to help each other, all of you, and even ourselves, to get healthier. We have to start pregnancy from a healthy standpoint, and that is a conversation that we need to be having before the woman shows up for prenatal care, and we don't do that very well. So if I see a woman, let's say today she's in the office at 30, I need to be asking her, what are your goals for growing your family? Whether it's going to be her first or her fifth, sixth, or seventh, it doesn't matter. What can we do today to prepare? And unfortunately, here in Georgia, we are at the top of the list for morbidity or mortality. And one of the things, and I know that y'all are from other places, I got Fort Lauderdale, I got Chicago, I know people are from different places, but let me just give you some numbers here. In Georgia, we have 159 counties, 159. There, as of today, when I put it in ChatGPT the other day, I've been saying, oh, it's 81, it's 82 now. Counties that do not have an OBGYN, not one OBGYN. Hospitals are closing. So if I live in rural Georgia, how long is it going to take me to get to my appointment? And when am I going to be able to get, where am I going to go to the hospital? What's the nearest hospital? We had, a hospital, a major institution right here to close about two years ago. So and even as Dr. Bussy Jones mentioned, and we talk about racism in medicine, there are many, many, many layers. And so let's start with the conversations about where, hey, doc, my husband or my partner and I are thinking about starting our family. Start that conversation before you're coming in to pee on that stick.
We're going to switch gears again. We're trying to stay on. We're going to let you all ask your questions. We're trying to stay on point. Next, we have Dr. Vivian B., who is a breast surgeon extraordinaire. And she's going to tell us about herself and what she's doing. And she's not going to tell you this, but I'll tell you, she just graduated. Now, she's an MD, and she just got 2 more degrees. Just got her MBA and another master's at the same time. And she's one of my former students, too, so that's why she's doing so good.
That's why he's giving you a shout-out. I appreciate it.
I was very young when she was my student.
Very, very young. Very, very young. So I am Vivian Jolly B., Dr. Vivian Jolly B. I am a breast surgical oncologist, which means I trained in general surgery, so I'm board certified in general surgery, and then I went and got specialty training in breast disease. I am on faculty at New York Presbyterian Weill Cornell Medicine, which is in New York. So I will say this, when Dr. Jones called, he is such a wonderful mentor. I said, absolutely, I will be here. So I came all the way down from New York. I run the breast program in Brooklyn, and I take care of all things breast health.
All right, well, thank you.
Oh, sorry, and shout out to, because we're deep in here, to the illustrious women of Sigma Gamma Rho Sorority Incorporated.
And that reminds me, I'll say it before I forget, I tried to find some, actually I had a good friend who's Phi Beta Sigma. I tried to get him to come. He's out of the country. Tried to find some Zetas to participate and out of Phi Theta. And it was a puzzle fitting everybody together for the specialty. So we did not want to exclude anybody, but we don't have anybody today from Phi Beta Sigma, Zeta Phi Beta, or out of Phi Theta. Those are our divine 9 brothers and sisters. Just wanted to say that. Tell us, first of all, start talking about black women and breast cancer.
Yeah, so when I was at Morehouse School of Medicine, I realized at that time the importance of really taking care of our community, and I saw a pathway within breast health. What we know as far as statistics is that breast cancer is the #1 cancer diagnosed in women. It's the 2nd leading cause of cancer-related death in women. And unfortunately, for black women, we have a 40% higher mortality compared to white women. Now, the cause is so multifactorial. I give lectures and host courses on this, on how we can really sort of move the needle and narrow that gap. But those are the statistics. We know that black women are twice as likely to be diagnosed at a younger age, which we're going to get into screening and the age that you can screen because it's really confusing. We also know that black women are twice as likely to be diagnosed with a more aggressive breast cancer called triple negative breast cancer. Now, I can go through all the statistics and, sort of put fear out there, but that's not the goal. The goal is to say we can do some things to take care of our health, and we're going to talk about that today.
Yeah. And speaking of that, when should a woman, first of all, let's do this. Should women still be doing self-breast exams?
Absolutely. Now, I will say that because some of my primary care will say, well, the data says that you shouldn't, and da-da-da-da-da. But I can tell you that I have women who are doing their breast exams and who actually caught their breast cancer because they were doing their breast exams. And I do work on the continent of Africa, and we know that that is a tool that is used I wouldn't say successfully, but it's used to catch breast cancer. So yes, you should do your self-breast exams. Now, we can say do your self-breast exams, but not show you how to do it. So what I tell women, my black women, is when you go to see your primary care physician or you go see a breast specialist, as they're doing the exam, pay attention. Ask them, what are you doing? You're using the tips of your fingers, you're feeling your breast. Feel your breast when you leave there so that you know this is normal. So that if anything changes, you are on high alert and you can advocate for yourself. So absolutely self-breast exams are necessary. And the signs and symptoms for breast cancer are, and not exclusive, but are lumps, bumps in your breast, also fill up underneath your armpits because we know breast cancer can go to lymph nodes underneath there. Nipple discharge. Not all nipple discharge is bad. If you're breastfeeding, then you're going to expect nipple discharge. There's bloody nipple discharge, there's milky nipple discharge. Go to your doctor to discuss. Skin changes. So if you notice that you have eczema all of a sudden, right, on your breast, and I'm gonna treat it as eczema, go see somebody because if it wasn't there before, then it may not be eczema, right? So those are the signs and symptoms for breast cancer.
And tell us very briefly if a woman has a family history, and tell us about what first degree family history is. Well, how does that affect their risk of developing breast cancer? What should they do?
That's a great question. And what I'm actually going to lead with is one of the biggest myths, because I don't want to forget to mention this. Just because you do not have a family history of breast cancer does not mean that you will not get breast cancer. In fact, the majority of patients that we see who are newly diagnosed with breast cancer have no family history, right? So we're not going to lean on that. With that being said, if you have a first-degree relative, a sister, a mother, who has breast cancer, you are very likely at higher risk. Some of the guidelines, so I'm gonna jump into guidelines because there's so much, There's so many different guidelines that it makes it confusing, and even confusing for your primary care physicians. The guidelines were made, many of them were made without black women in mind. So I'll just jump right in, right? And so as a breast specialist, I advocate for my patients so that we are really not just looking at the guidelines. If they don't fit into the bucket of what we need to be doing, then we talk about how we need to get you screened earlier. Currently, the guidelines say that if you're at average risk for breast cancer, that's typically you don't have a family history, you haven't had breast biopsies, then you should start your mammogram at the age of 40, okay? And some of the guidelines say you should do it every other year. Now, we advocated for this. We were sitting at the board table because they said actually start at 50, and then we said, well, black women weren't included in that data. It was based on European countries, right? So how do we translate that to our black population? So age of 40, and they may say every other year. We want you to get it every year, okay? But I just said average risk, so this goes to Dr. Jones's point of family history. Well, how do you know if you're average risk or you're high risk? It's not just based on family history. So we're now saying, and this is what I want you all to take away because not a lot of people know it, but at the age of 25, so if you have daughters, nieces, cousins, whatever, they need to be getting the high-risk assessment at the age of 25 by a breast specialist. We have specialty tools that can help us identify those people who are high risk, which means maybe you need mammograms or MRIs or ultrasounds before the age of 40.
Okay. And we're gonna come back and get your questions, and please let's come back and talk about triple-negative breast cancer. But we're gonna move on to the brothers for a minute, and we have Dr. Brittany Barrett Harlow, who is a urologist. And tell us who you are.
Yep. So I'm Dr. Brittany Barrett Harlow. I'm a board certified urologist. I practice with Georgia Urology down in the Fayetteville area. And I am a proud member of the phenomenal women of Delta Sigma Theta Sorority Incorporated.
Oh
Thank
my
you,
goodness.
sorors. So I specialize in men's health. I did some extra training in that. So I see a lot of men for not only prostate cancer and BPH, but also erectile dysfunction, penile curvature, low testosterone.
Let's start with BPH, something I know a little bit about. Tell us what BPH is and
So,
how you treat it.
so BPH actually stands for benign prostatic hyperplasia. But for everyone else, it's your husband getting up in the middle of the night to use the bathroom, okay? So typically around the age of 40, 50, the prostate starts to grow. The prostate is God's gift to the urologist because it doesn't really do a lot for you, but it causes a lot of problems. So you can have issues with waking up several times in the middle of the night to use the bathroom, slow stream, going to the bathroom frequently, can't make it to church and sit through the service without getting up several times. So all of that is signs of an enlarged prostate. And a lot of men kind of just live with it. So I always tell my female patients, bring your husband in too, because it is something that can be detrimental long term.
And we'll come back and talk about treatment in a minute, but I want to switch gears again to something very important, prostate cancer. Prostate cancer in black men especially. Talk to us a little bit about that.
So prostate cancer is similar to breast cancer. It is the most common male cancer, second only to skin cancer for the whole population. And when we think about our black patients, it is more common and more aggressive. So typically it's 1 in 8 men in our white counterparts, but in black males, prostate cancer happens more frequently at 1 in 6. And not only are you more likely to be diagnosed, but you're more likely to be diagnosed at a younger age, 40, 50 years old, as opposed to 60, 70. And you're more likely to be diagnosed with more aggressive disease, a higher risk disease. So it's important for my black males, make sure you are being seen and you're being screened, just like we've been talking about. That's a PSA blood test every year, not every 2 years, every year. You're black, you're at a higher risk. Your PSA number changes based upon your age. So although they say 4 is the number, if you're 50 and you're black, it should be 3. And that's where we go to having a doctor that looks like you, that's not just treating the broad picture, but treating you specifically. So you want to get your PSA tested, you want to get your rectal exams. You don't like it, I don't like doing it, but we got to do it. And that's the way that we know we don't feel anything that's concerning. Because you can have a PSA that's 1, but if your prostate is rock hard and I feel something abnormal, that's cancer until proven otherwise.
Okay. Talk to us a little bit, and we'll come back to erectile dysfunction. We know men, brothers, running out the door already. They don't want to talk about it.
Come back.
They don't want to talk about it. And I have to admit, when I was putting the panel together, we actually had another urologist that we had asked, another one of my good friends, and I was asked, oh no, well, Dr. Harlow, she's great. You know, she participated last year. Me and my ignorant self, I said, I don't know if a female urologist would really be able to sympathize and empathize with a man. And my wife looked at me like I was crazy. She's like, what are you talking about? And so I went to LinkedIn and looked up Dr. Harlow, and she is she is a specialist in this. This is what she does. And I felt so stupid. And so I am so glad that she's here and she's corrected me, and I know better. But tell us a little bit about erectile dysfunction, the brief version, and then we'll come back to it.
So ED is not a zero-sum game. It is not you can't get erection at all or you get great ones. It's a change to the quality or characteristics of your erection. So if it's harder to get an erection, if it's not as hard, if it's not lasting as long as it used to, all of that is ED. And the one thing that I will say is that saying, if you don't use it, you lose it, is true in erections. So don't wait and wait and wait to be seen. Because as you wait and wait and wait, it becomes harder to treat and you lose length. And there is nothing I can do to regain length or girth. So if you want to keep what you got, then you need to be seen sooner so we can address it sooner.
And how common is it?
So 50% of guys over the age of 50.
Okay. Pretty common. Pretty common. Let's get some questions from the audience on any of these topics. Brother Lyles, can you? Okay. Okay.
Good morning. My name is Jimmy Prude, and I'm from Chicago. And my question is for the endocrinologist that spoke with regards to diabetes. I wanted to, sorry. Oh, my bad. I wanted to, I had a question regarding to, how important is it with regards to lifestyle change and incorporation of certain foods for type 1, type 2 diabetics, and maybe even pre-diabetics, specifically for zero sugar and keto-friendly type products? And is there an association between people who have gluten sensitivities and higher rates of diabetes? Or diabetics?
Great question. Thank you for that question.
No, that's fantastic. And I'm internal medicine, so I can't claim endo all of a sudden. But so the first part of your question, I think, was about the importance of lifestyle, right? So lifestyle changes are huge. And anytime I have a patient coming to me who's pre-diabetic or diabetic, I am going to definitely talk to them first about lifestyle modification. It is always the right answer, all right? And it's not drastic changes that can make huge changes in numbers like A1C and diabetes progression, all right? So I'll tell my patients a 5 to 10% body weight loss. I don't care how you get there. That can diminish your chance of developing diabetes over your lifetime by 50%. All right, so huge changes there. And then talking about, so type 1 and type 2 are very different. All right, type 1 diabetics, typically we used to see before the age of 18, and the problem there is pretty much that your pancreas stops working. All right, your body attacks itself, your pancreas is not working, you don't make insulin. Without insulin, you will die. All right, so these patients need to be on insulin. But we're seeing type 1 later and later also. Type 2 is the most common by far, which is 90 to 95% of diabetics, and that is the lifestyle piece, okay? So you may have family history, you may have this, you may have that, the socioeconomic factors and all that, but I tell people the genetics and all is kind of what loads the gun. Your lifestyle pulls the trigger, all right, to get you into that diabetic space. We know that anti-inflammatory diets, and gluten has a lot of pro-inflammatory properties. So we know when we look at the molecular and the pathophys behind what's going on, this is a disease of inflammation and insulin resistance. Your body is not using the insulin that it has appropriately to do what it needs to do. And in time, sugar builds up in your body and in your organs, and that's what is lethal over time.
Thank you. Thank you. We're gonna, after this, we're gonna have like a mix and mingle, but we got a whole new section. We'll get to you, but we gotta keep going. One more question here, and then we're gonna have the next group of panelists come up. So nobody leave. We got some more very exciting topics coming up.
Good morning. I'm Andrea from Houston. Piggybacking on that question, can you guys speak to the benefits of fasting, water fasting, intermittent fasting? We hear so much information. What is a good guideline for fasting?
Now, they don't usually teach us that in medical school, which is so bad. So I know there's some experts in here that know a little bit more about that. So
one thing I will comment about intermittent fasting is there have been a lot of studies and data out of Europe that they've been doing this for a longer period of time, and we see improvement of metabolic parameters. So A1C, fasting blood sugar, triglycerides, weight, etc. All right, it has to be done under a medical professional's guidance, I would recommend, just to make sure, because it's not for everybody, right? If I'm an insulin-dependent diabetic and I'm fasting all day, that's not going to end well. So the theory behind it is that you're giving your pancreas rest, right? You're giving it a chance to reset. You're giving your pancreas a chance to rest and not just be pumping out insulin as a response to sugar that's either ingested or made by your liver. So it does have a lot of benefit. I still think that there's a lot of research and study being done to really determine what's the actual best recommendation for you.
All right, our panelists are still going to be around. You can ask them some more questions. We're going to mix them in a little bit, but let's bring up our next group of panelists. So give this group a hand.